Tantor Audio, a division of Recorded Books, presents Reproductive Injustice, Racism, Pregnancy, and Premature Birth by Dána-Ain Davis, narrated by Allyson Johnson. Publisher's note: this audiobook refers to figures, tables, and charts included in the print and e-book editions of the book. Preface. This book is about race and medical racism, Black women, and premature Black infants. When I first set out to do this research, I thought the focus was going to be solely on neonatal intensive care units, NICUs, the specialized hospital units dedicated to providing extensive medical attention to newborns who are premature or otherwise ill. But looking at NICUs, I realized, also required looking at Black women's birthing experiences. Black women have higher rates of premature births than any other women in America, and these rates of prematurity go beyond class. One might expect that lower income and poor women would have higher rates of premature birth because of lack of care or resources. Yet among Black women, being middle or upper class provides little protection from the precarity of prematurity in ways that do not hold true for women of other racial backgrounds. This book looks into the dynamics of how this may be the case. Placing these differences in birth outcomes into a historical context, the book shows how contemporary ideas about reproduction and race have been influenced by ideas that developed during the era of slavery. This book had its origins in a party I attended to celebrate the 40th birthday of a friend. The celebration was hosted by Eric Johannes, a physician. Copious amounts of good eats led to a lot of banter. A discussion ensued about the number of work-related obligations we each had in the coming weeks and the particulars of our respective professions. Eric joined in and announced that the following week he would be flying to another state to be on call, a kind of work I was unaware doctors did. I asked him to describe his job, to which he responded that he worked in a NICU as a surgeon, providing specialized care for congenitally ill and or premature newborns. Intrigued, I began what became 7 years of research on neonatal intensive care units and prematurity. Typing those words into a search engine revealed an interminable stream of announcements about hospitals breaking ground for new or expanding NICUs in Texas, Louisiana, Pennsylvania, and Illinois, among other places. Nearly every state had a NICU expansion story. As I began to conceive of a study of these units, Eric Johannes, the surgeon who had hosted my friend's birthday party, agreed to be interviewed and arranged to give me a tour of the NICU at his hospital. I had initially intended to explore the meaning doctors and nurses gave to NICUs and had no intention of talking to parents of children who were or had been NICU patients. I worried that it might be too painful for them to relive such a crisis as dealing with their premature or sick child. Ultimately, I did end up interviewing parents, largely because of a fortuitous meeting followed by a discovery. It was that meeting and the subsequent discovery that opened up my research beyond my initial ideas, in the end leading to this book being about pregnancy, prematurity, race, and racism. The fortuitous meeting occurred in the fall of 2014, after I gave a talk on NICUs at a university in Illinois. At the end of the talk, a young Black woman named Ashley approached me and said that she wanted to share the story of her pregnancy and premature birth with me. Ashley's description of how she was treated during not one but 2 pregnancies raised a number of questions about the racial dimensions of prematurity and the technologies used to save premature infants born to Black women. Ashley felt that doctors had misdiagnosed issues that arose during her pregnancy and that racism had something to do with the care she received. I began to wonder what other women, especially women of color, thought and felt about giving birth prematurely, and what role they believed race and racism played in their pregnancy, their treatment, and the admission of their children into the NICU. After hearing Ashley's story, I found myself remembering my own pregnancy, which I had not thought about in many years. Similar to Ashley, I had become pregnant when I was in college. In 1980, like Ashley, I too was single and working for hourly wages at the Maya Gallery in Washington, D.C. On the top floor of a beautiful brownstone in the moderately renovated hot attic, I framed pictures. I also organized events, such as when Olabisi Olaniyi, the wife of the famous Yoruba modernist artist Prince Twin 77, exhibited her work at the gallery. Within my remembrance of my own birth story are many of the themes and threads about Black women, race, and prematurity that are the focus of this book. My birth story. Being near broke, which is not the same as being impoverished, forced me to identify resources that would facilitate the birth of the baby whom I wanted so badly. Although not a Seventh-day Adventist, I applied for and was admitted to a hospital-based clinic program for low-income women at the Seventh-day Adventist Hospital in Tacoma Park, Maryland. The arrangement required making monthly payments to cover the cost, which I recall was $700, based on a normal full-term vaginal delivery, or about $2,000 in 2018 dollars. One morning in the spring of 1980, in my second trimester, I woke up bleeding. Scared, I made an appointment at the clinic. I had an ultrasound, the only one I received during my pregnancy. After consulting with the technician, the obstetrician, who was a white male, came into the examining room and told me it looked like I might be having twins and that one was a girl, which was good because girl babies are strong. From the sound of his voice, which was foreboding, I assumed that I might lose the twins. After all, why would he say girl babies are strong? He asked what I did for a living, and I said I framed pictures and organized exhibits. He also asked a number of questions about my educational status, family background, and marital status. In retrospect, I do not think he was actually interested in me as a person. In fact, I thought his questions were condescending, in part because it seemed as if he was trying to find within my narrative a stereotypical thread about the young-looking 22-year-old black woman who sat before him. That is how I would characterize the doctor's questions, predicated on assumptions that my family or I were potentially pathological from his perspective. My perception was that he was judging me based on ideas nourished by my race, my age, and the fact that I needed charity care. There was nothing in particular about what he said, but there was something about his tone and how he asked questions. I was just uncertain that he was not insinuating something based on his questions. Frankly, that interaction made me feel like I did not want to see him again, which was not a problem, since in the clinic I rarely saw the same doctor twice. His final warning to me was that I should be on bed rest for a month, or I could lose the twins or go into premature labor. After leaving the doctor's office, I went to see the social worker assigned to my case. What assigned really meant was that she wanted to ensure that I made my payments. At least, that was what I surmised. When I arrived at her office, we discussed what would happen if I had a premature birth, and the social worker informed me that my final payment would skyrocket. That was her primary focus, skyrocketing payments. I resented the entire conversation. Prematurity is scary, and no one is really ever prepared. I have no recollection of ever being informed why I was bleeding, what it meant to have a premature infant, what the circumstances were that could precipitate such a turning point in my pregnancy, or the consequences either for me or for the babies. My fears were not centered on the possibility that a neonatal care unit was in my future, because at the time I did not really know what that was. What concerned me more was losing the babies and the possibility of having to pay far more than I could afford for anything other than a vaginal birth. As it turned out, my ultrasound was misread and I did not have twins, nor did I go into labor early. However, I did have a cesarean section, C-section, which increased my final payment by about $250. The hospital pestered me for several months until it was paid off. My recollection of that event was precipitated by the interview with Ashley, and it made me feel as if our paths were similar. In some ways, neither of us knew what was going on with our pregnancies, and neither of us had been told about the consequences of premature birth either. Inspired by the similarities in our respective situations, the focus of this project centered on Black women's specific experiences with prematurity. The research was also driven by the fact that in U.S. politics, as many scholars have pointed out, women have been largely erased from the issue of reproduction. Indeed, the politics of reproduction have generally focused on fetuses, newborns, and infants. This book brings women, specifically Black women, to the center of inquiry on the social context of reproduction. Rediscovery. Later, one winter night in 2015, I made a rediscovery that led me to focus on prematurity. In a search of historical references offering definitions of prematurity, I came across a document that in 1948 defined prematurity as a pregnancy that has ended at 37 weeks. 3 pages later, it stated that since gestation was only an estimate, a neonate, defined as a newborn less than 28 days old, with a birth weight of 5 pounds and 8 ounces or less, regardless of the estimated last period a woman reports, was premature. I recalled my mother mentioning that I had been born early by about a month. After searching for and finding my baby book, there it was. I had weighed 5 pounds and 6 ounces. So, according to the document's definition, I was considered premature. Ashley and I, 2 Black women separated in age by more than 3 decades, had somewhat similar encounters. The circumstances of our pregnancies were similar, and both of us were apprehensive about the interactions we had with our medical providers. We were both women with some college education. I was to graduate in the fall of 1980, and my daughter was born in 1981, at the time of our pregnancies. Depending on one's definition, we would both be considered middle-class women. Class, of course, is a fuzzy category, as anthropologist Emily Martin has noted. Those in the middle strata include both people in professions and those who possess access to resources that offer greater autonomy, responsibility, mobility, and prestige. However, class is also raced in different ways, depending on gender. For instance, women who are working and middle class are often understood to be white, whereas Black women are often viewed as being low-income or poor. Ashley and I had access to resources, and our class position intersected with race. From our respective perceptions, it was race that confounded our medical treatment and the care we received. So, while class was the presumptive factor that may have positively orchestrated our health care, as many believe is the right that comes with class, our race preempted the social capital that supposedly accompanies particular class benefits with regard to that care. We were 2 Black women. There is also the fact that Ashley was just as likely to have a premature birth in 2008 as I was in 1981. That reality did not coalesce only around class. It was race that was the defining feature that made each of us twice as likely as white women to give birth prematurely. Race mattered for us because white women do not fit into the dominant narrative that moves across the American imaginary about who gives birth prematurely. It is Black women who hold that place, and it is Black women who are castigated for their reproduction. Importantly, for both Ashley and me, in our medical care interactions, neither of us was able to shake the feeling that some degree of racism had sabotaged a part of our prenatal care. We were not always quite certain how race and racism mediated the care we received during our pregnancies, but we knew it did. That is what this book is about. Black women's narratives of prenatal care, pregnancies, and prematurity, and their understandings of the racism they experience as they strive to give birth to children who will thrive and to give voice to the ongoing legacy of racism in the way they are treated, a legacy now several hundred years old. Being born prior to full term almost always leads to admission of a newborn to the NICU, so the NICU became the conversational place of departure from which I learned about Black women's thoughts on prematurity. I wanted to hear their viewpoints regarding what contributes to premature birth and to experiences in the NICU. I was especially interested in how they and their infants were treated by doctors, nurses, and others involved in the care of their children. This is a topic with which you probably have some familiarity. The popular press regularly reports on Black women's adverse birth outcomes. A search in the New York Times for the term Black women premature birth showed 65 results between 2007 and 2017. Although you have probably read about Black women and infant mortality, Black women and low birth weight infants, and Black women whose babies are born too early, This book tells the contemporary story of pregnancy and premature birth against the backdrop of the legacy of slavery. It underscores the history of Black women's reproductive exploitation and reminds us that Black women have had to endure a medical structure that has historically not really viewed them as worth caring for. I mean, really caring for. I listened to women and some men share their stories. On the one hand, they spoke their truths about pregnancy, laboring, birthing, and for most of them, waiting for their newborns to be discharged from the NICU. On the other hand, their descriptions sometimes hint at or boldly demonstrate the gradations of racism in medical encounters. These gradations include cases where racism was not felt or perceived by Black women and men. For instance, whereas some women felt the derision of racism, others did not. Yet it is important to point out that even if the people with whom I spoke reported not having had to confront racism during their medical encounters, this does not mean racism is not operating within the medical system. One of the primary claims of this book is that in issues of reproduction and prematurity, race matters. Racism matters. This holds true even when there is no direct impact perceived by those receiving treatment. The data and statistics support and plainly illustrate this claim. The geographer Ruth Wilson Gilmore usefully defines racism as the institutional and state-sanctioned practices that make particularly designated groups of people vulnerable to harmful outcomes and premature death. Others, such as Omi and Winant, have analyzed the ways in which racial groups are formed. Focusing on how race and racism are understood and felt by Black women in their medical encounters while pregnant and after their babies are born and enter the NICU, this book looks at experiences of racial inequality at the very start of life and from the point of view of racialized childbearers, that is, Black mothers. At the heart of this book are an understanding and an analysis of how these women characterized their interactions with medical professionals regarding the care they received, or did not, during and after their pregnancies, and the ways that medical racism continues to contribute to differential life chances in the contemporary United States. Medical racism refers to much more than the care that is rationed by the medical profession, as Dr. H. Jack Geiger, one of the originators of the community health center model in the United States, has pointed out. Medical racism also includes the sometimes subtle and sometimes not so subtle ways in which the medical complex, in each of its parts, cumulatively dismisses, misdiagnoses, and undermines women's feelings and intuitions about their reproducing bodies, and, more specifically, disproportionately undermines Black women's reproduction. This book, then, views medical racism as a problem that transcends individual doctors and medical professionals. It also views medical racism as compromising more than individual women. In exploring the meaning and interpretations women have of racism by analyzing their oral histories, here referred to as birth stories, this book examines medical racism and Black women's reproduction as a complex cultural system with deep historical roots. As women shared their birth stories, their circumstances of conception, what their pregnancies were like, and how they felt during labor, birthing, and after, I was struck by how much of the content of their contemporary narratives resembled accounts of medical racism from centuries past. Thus, these women's accounts illuminate the ways in which historical structures and conceptions of race are inextricably tied up in contemporary medical understandings of prematurity and pregnancy in the 21st century, drawing our attention to the existence of a medical racism that continues to operate today, often similar to ideas and practices that originated during the era of slavery. Introduction. How do you keep the Black female body present, and how do you own value for something that society won't give value to? Claudia Rankine. In 2008, Ashley Bay, a 19-year-old African-American woman from Illinois, was a college student when she became pregnant and then delivered a little girl, Jamie, 3 months early. We met after I gave a talk in 2014 at a university in Illinois about my research on neonatal intensive care units, NICUs. She brought both of her children, Jamie and Justin, to the talk. Jamie sat on the side of the room coloring while her mother rocked the carriage in which Justin was sleeping. An hour later, at the end of the talk, Ashley tremulously made her way to the front of the room where I was standing. I saw her from the corner of my eye, but I was engaged in conversation with some of the faculty who had attended. Ashley waited patiently. After I finished my conversation, I turned and gestured for her to come closer. She appeared uncomfortable, so I made small talk and chatted with her daughter, which seemed the best way to ease Ashley's discomfort. After a while, there were only about 2 or 3 other people left in the room. As they conversed with each other, Ashley looked at me and said in a hushed tone, "My daughter and son were premature, and I would like to talk about it." In social science research, we hardly ever have people asked to be interviewed, but she and I exchanged contact information. The plan was to let her take the lead in contacting me. I suggested she call me when she was ready to talk about the births of her children. Ultimately, that conversation with Ashley would help to alter the shape of this book. Her story, as we will see, exemplifies a common problem. Black women are more likely than any other women in the United States to experience premature births and to have low birth weight infants. This book, in part spurred by that fateful conversation with Ashley, undertakes a historically grounded discussion of this phenomenon. Ashley's story is one of the many I collected during 7 years of research that have culminated in this book. I argue that some pregnant black women like Ashley experience medical encounters reminiscent of racist medical practices and beliefs that have persisted from the 1700s. My attempts to understand the historical roots of those experiences took me to medical journals, historians' accounts, and other sources ranging from the 1700s to the 21st century. Using the afterlife of slavery framework as a critical lens to situate medical professionals' practices, this book explores how black women's prenatal care, labor, birth, and treatment in medical environments are extensions of 18th, 19th, and 20th century racial thinking. My analysis shows that despite the determined efforts of medical personnel, of the staff of agencies working to reduce adverse birth outcomes, and of birthing and reproductive justice advocates, the power of race and racism cuts across the American class divide, producing racial disparities in infant mortality and prematurity rates that call into question the efficacy of the technologies of saving pursued by advocates of NICUs and the health education campaigns used by public health proponents. After the talk at which I met Ashley, I was driving to the airport and heard a weather report on the radio. The waters of Lake Michigan were surging. My palms felt as wet as the lake from anxiety, sweaty as I considered the implications of now including women in my research on NICUs. How could I tell their stories about pregnancies and births in ways that did not reproduce ethnoporn, a term I use to describe sustained ethnographic descriptions of incidents weighted down by graphic detail? Concerns revolving around power dynamics and ethical relationships between researcher and informant have been taken up by feminist scholars for several decades, and these matters also preoccupied me not only as a researcher but as a black mother and as a technically premature birth myself. It was not so much that I feared an ethical dilemma about the research, although I wondered what feelings might emerge as a result of women reliving the memories of their difficult pregnancies and the births of their children. Rather, I wanted to be mindful of the choices I made in sharing the women's experiences, of the analytical pitfalls and incentives that sometimes accompany such research. For example, narrative data presented in talks and panel discussions, often with predominantly white audiences, sometimes introduce the risk of narrowly positioning black women primarily as victims. Like literary scholar and author Roxane Gay, who describes how her discussions of being raped might be the only thing that would make her memorable, I was concerned that women's accounts of adverse pregnancies would be the only way in which they might be remembered. After consultation with some of the women who participated in the project, I determined that there was no way to anesthetize women's descriptions of pregnancies that ended up in premature birth. If the women were willing to disclose the trauma of their pregnancies, labors, and births, then I would not write around what happened or the feelings that surfaced. And indeed they were willing. Their narratives led me to see how black women interpret their births and how some resisted the shroud of adverse outcomes. Many do this by finding comprehensive care and alternative birthing methods. Women shared their encounters, hoping that others might benefit. So it is with great humility that I share their stories with you. 2 months after we met, Ashley called, and we agreed to connect in a phone interview a few weeks later. When we spoke that first time, hardly any niceties were exchanged. Ashley launched right into what happened during both of her pregnancies. The reason for the first premature birth, Ashley revealed, was that she had placenta previa, a condition in which a placenta partially or totally covers the opening in the mother's cervix. The placenta, which provides oxygen and nutrients to the developing embryo and removes waste products from its blood, is attached to the uterine wall from which the umbilical cord arises. In most pregnancies, the placenta attaches at the top or side of the uterus, but in Ashley's case, it was attached at the lower end of her uterus. Because placenta previa can cause severe bleeding before or during birth, care providers recommend that women who are diagnosed with this condition refrain from physical exertion for a portion of their pregnancy. Despite bed rest, it is still likely that these women will have to undergo a C-section. Just after Ashley disclosed that she had given birth prematurely, there was a pause. She inhaled, then exhaled. Her deep breaths seemed to propel the energy she needed to continue her story. After the exhale, Ashley was calmer than before as she described her pregnancy. After she found out she was pregnant, Ashley took a leave of absence from college, moved home with her parents, and began working at a part-time job. She also signed up for All Kids, an insurance program for low-income people, during her pregnancy. Ashley had an ultrasound during her first trimester, and everything seemed fine. But during her second trimester, Ashley began to sense that something was wrong. She just did not feel right. Her concern precipitated her request for an additional ultrasound, but she said her doctor told her, "No, we don't want to give you another ultrasound because we don't want to hurt the baby." During that same visit, Ashley asked the doctor again, and he responded that she did not need one. Ashley recalled, "After that I was afraid. I thought I was going to have a miscarriage." One weekend, when her parents were out of town, things took a turn for the worse. Ashley shared with me, "It was early in the morning. I was confused, scared, and bleeding. I went to the hospital, and they put me on magnesium for hypertension so I wouldn't have seizures. I was at a teaching hospital. The nurses wanted to put in the IV, but I was swollen. My hands looked like I was a drug addict. The people at the hospital were talking to me, but I did not hear what they were saying. I finally only understood what was happening because my grandmother and my aunt, who were both medical professionals, RNs, came later and explained what was going on with me." It was at this point that Ashley's placenta previa had been diagnosed. In a brief departure from the story of her unexpected labor, Ashley then began to tell me about her aunt, who had been a midwife for 10 or 15 years. I think this was Ashley's version of taking a small break, because when she resumed talking about the birth, she began talking rapidly. "When I arrived at the hospital, they tried to keep me on bed rest most of the day. They had me on machines and kept a close watch. They were hoping that the bleeding would stop. But then Jamie's heart rate dropped, and they performed an emergency C-section. Jamie was born at 26 weeks and weighed 1 pound and 8 ounces. She received a steroid shot to help with lung development, and then they took her to the incubator in the neonatal intensive care unit. I was in the hospital for about 3 days. Jamie was in the hospital from January 10th to March 6th. It is January 9th, I thought to myself. At that moment, I realized we were having our conversation just 1 day before the anniversary of Jamie's arrival. Worried, I wondered if it was too difficult to continue the conversation. Should I offer to end it? I asked, but Ashley said she wanted to continue, although just after sharing with me the details of her admission to the emergency room, there was silence on the phone. I broke it. "Ashley, how did they treat you and Jamie in the NICU?" Ashley responded, stating, "They treated Jamie fine. The NICU care was good." Her response was not entirely accurate, because later, during our conversation, Ashley shared two disturbing incidents. First,
sample complete. Ready to continue?